Hi folks, Professor Gulliford here. Let's go ahead and do a screen share. We have just one more chapter to cover before your midterm. I believe you will do very well on your midterm, and I'm rooting for you. Just a reminder, the review sheet is the key, and that will be true with all of my exams. I don't believe in hiding anything or, trying to play any games. I tell you what you need to learn. You go learn it, you take a test on it, and you move through. So just please focus on that review sheet, and I think you will do very well. I am rooting for you to do very well. I am cheering for you. So you'll get it out of your way. We'll get it out of your way, and then before you know it, you'll be done with the course and you'll take the final, and there'll also be a very good review sheet for that. Hemodynamics. We're going to just touch on this. It's pretty early in your process to go into a lot of detail on hemodynamics, but I do want to mention it's blood flow through the lungs, through the heart and lungs is what we're talking about here. And a couple of key concepts are the use of nitric oxide as a pulmonary vasodilator to open up the blood vessels in the lung, and pulmonary edema, where fluid backs up into the lungs. That will have a high wedge pressure. High wedge pressure. There we go. And we'll explain that a little more in detail here. Blood flow has to go through the lungs about 5.5 liters every minute. Think of that. Every minute, 5.5 liters of blood comes through your lungs, picking up oxygen, dropping off carbon dioxide. It is pulsatile flow. I've never heard of Wormersley flow, so I don't think you will either. But it is pulsatile flow, meaning it's not just static. It's pulsing as it moves through. And here is a picture that shows you the whole course that it takes. Let's go into the right atrium, then right ventricle, then pumped out to the lungs, picks up oxygen, drops off carbon dioxide, then back to the left atrium, then the left ventricle, and then pumped out to the body, and then back through the veins to the heart. So we're going to measure pressures along that path, and that's what hemodynamics really is. We measure total blood flow through the pulmonary capillaries, also distribution of blood flow, meaning how well does it match up with the air coming into the lungs, and mixed venous blood flow, that is in the pulmonary arteries. You'll learn a lot more about this in your critical care course, but we'll just introduce it now. Yeah. So it is important to figure out how much oxygen is coming in and also how much blood flow is coming in. And the combination of those things is sometimes called VQ ratio. So I'll just mention that right here, VQ ratio. And students have said to me for all these years that I've been teaching, why is it a Q? Well, the Q is a French physiologist meant the quantity of blood flow. So the blood flow, the ventilation to blood flow ratio is called VQ. That's confused people for years and years. Ventilation, perfusion ratio. Perfusion refers to blood flow. Ventilation obviously is the oxygen coming in. So there we go. Anatomic dead space is just the tubes leading down to your alveoli. It's the first, about 20 branches of the respiratory tract. And the amount of anatomic dead space for a lot of patients is about 150 milliliters. And there's a way to calculate that. You just take the patient's weight in pounds, not kilograms, but pounds, and that will be the anatomic dead space. Somebody who has an ideal body weight of 150 pounds will have an anatomic dead space of 150 milliliters. So I'm going to say 1 milliliter per pound. It's one of the few things in medicine that we do by pound instead of kilogram. 1 milliliter per pound of ideal body weight. We will calculate ideal body weight together one day, and I think you'll be, like most Americans, a little shocked. This professor probably weighs 30 pounds more than ideal body weight, and that turns out to be true for an awful lot of Americans. That's what it is. Alveolar dead space, those are the alveoli that are not participating in gas exchange. They might be full of pneumonia. They might be collapsed and unable to participate because of that. Um, and then physiologic dead space is the total of anatomic and alveolar. So that is a formula that you'll want to hang on to there. You'll wind up using it. I don't think it's on the midterm, but it is one that you will need, when you go to critical care class, not too far down the road. Mechanical dead space is anything that is between the ventilator circuit and the patient. Mechanical dead space sometimes is added deliberately so that the patient rebreathes a certain amount of carbon dioxide. But we don't do that very much anymore. So, you need to know the concept. I don't think you'll actually use it. It's anything between the ventilator circuit and the actual patient. Um, all right, pressures within the pulmonary system. Systolic pressure, as you probably learned in a biology class, a science class, is the pressure when the heart pumps. It's the active pumping pressure. Diastolic pressure is the pressure when the heart relaxes. And the difference is called pulse pressure. That is a board exam question. The pulse pressure, a normal blood pressure, as you know, is 120 over 80. Systolic 120, diastolic 80. The pulse pressure is the difference between the two. And typically it's around 40, just like you would do the math there. So this pretty important slide, systolic, diastolic, pulse pressure is the difference between the two. Let's see, left ventricle is more muscular. It's got a bigger job to do. It pumps blood to the entire body. The aorta arises from the left ventricle. It is the largest artery by far, and it gives you some dimensions here about the size and length. You don't need to know those, but the aorta is by far the biggest artery and carries blood out to the entire body. The pulmonary arteries carry blood to the lungs. Let's see here. Structure of the aorta and the vessels of the systemic circulation are thicker, and that's because they deal with much higher pressures. The pulmonary system is a low pressure system, as you're going to see here very shortly. Pulmonary arterial pressure, typically about 25. So pulmonary artery, about 25. Systolic, and about 8 diastolic. So the average or mean is about 15. Here's a board question for you. Pulmonary hypertension is defined as a mean arterial pressure, mean pulmonary artery pressure, greater than 25. Greater than 25. There you go. Actual pressures inside the pulmonary capillaries are estimated about 7 to 15. It's not really possible to measure that pressure directly. Pressure is likely to be about 12, 10 in the capillaries, 8 to 9 in the veins, something in that range. We do make a measurement of the wedge pressure, which is very valuable in that, and I will explain to you how we do that right there. But this gives you the pressures, pretty useful little picture, gives you the pressures all over the circulation at every point. So that is really quite useful. 120 over 80 in the systemic circulation, 24 over 9 in the pulmonary artery, about 8 as blood comes back to the left atrium. Very low as blood comes back to the heart through the veins, about 2, not more than 5 or 6. One of my professors said the blood barely makes it back to the heart. That's what nature wants, is for blood to just barely make it back. That's why veins have valves so that we can get the blood back. Trans means across, so transmural pressure is the pressure across the wall of a vessel. That comes up in pulmonary edema because we have too much pressure inside the vessel, not enough pressure outside the vessel, and we get fluid leaking. Transrespiratory pressure or transairway pressure is the difference in pressure between the alveoli and the surrounding air. Transthoracic is between the pleural space and outside of the body. Those two, honestly, we don't use very much. There are others that you will use. Intravascular, intrathoracic, intrapleural pressure, yeah. Um, Honestly, these are not things that you're going to use very much as a respiratory therapist. Um, there's just a picture of the various pressures, and there's nothing there that you need to memorize. Driving pressure is the difference between pressure at point A and point B in the system. That is the difference that is pushing blood through the system. Driving pressure is used for the pressure gradient that is moving really anything, but usually blood. It can also be used to describe the pressures moving air. Now, that's an important picture because that's where the business of healthcare takes place. That's where the life force, you might say, for life on this planet takes place. Getting oxygen from that alveolus. I just happened to see the macrophage in there. The Getting oxygen from the alveolus across the alveolar capillary membrane into the capillary so that it can be taken through the tissues. Also, removing carbon dioxide across that membrane so it can be exhaled into the outside air. So these are very low pressures, very small gradients that are required to make this happen. Let's see here. Pulmonary vasculature is very responsive to pressure changes. Yeah. And one of the things we're going to do is introduce you to nitric oxide as a way of opening up the pulmonary blood vessels. The alveolar vessels are the pulmonary capillaries. I just showed you a picture of that. And what they're doing is picking up oxygen and dropping off carbon dioxide. Kind of a miracle of nature that that membrane is so thin that gases can move across it. I think that's amazing, actually. Certain things can cause interference with that. For example, pulmonary fibrosis thickens the membrane so that oxygen does not diffuse as well as it should. Yeah. Mechanisms may be at work when blood pressure changes, and those are recruitment and distension. We can work on both of them, but basically what we want to do is open up blood vessels so the blood can flow more easily, unless the patient is in shock, meaning very low blood pressure. In that case, we want to constrict the blood vessels to raise the blood pressure. Swan-Ganz catheter. The Swan-Ganz catheter, I'll show you one when we have our next live session. I'll just actually hold one up and show you. But this goes into the pulmonary system. It actually enters the heart through the left atrium, goes into the right, enters the heart through the right atrium, then goes into the right ventricle, makes a bend, and goes up the pulmonary artery, and it sits right there in the pulmonary artery floating. It has a balloon which can be inflated to wedge it. That is, it will cause it to wedge in the pulmonary artery, and that allows us to estimate the pulmonary capillary wedge pressure, which they've mentioned right here. That is a very crucial number. Procedure is called right heart catheterization. On your boards, they won't use the word Swan-Ganz because that's a brand name. They're just going to say pulmonary artery catheter. There we go. And the procedure is called right heart catheterization. Under normal circumstances, the flow of blood through the circulation encounters pretty low resistance. It's pretty easy. The right ventricle has an easy job all of its life compared to the left ventricle because it doesn't have to pump very far and it doesn't have to meet much resistance. However, if the pulmonary vascular resistance is high, it causes a lot of problems. And we're going to actually show you how to calculate that. Yeah. That's coming up on the very next slide, I believe. The pulmonary vascular resistance is reported, get this, as dynes per second per centimeter to the fifth, or millimeters of mercury per minute per liter. And it does have a fancy name called the HRU Wood units. That's because people got tired of having to say that whole long-winded units there. But here's the calculation. It is mean pulmonary artery pressure minus pulmonary capillary wedge pressure divided by cardiac output times 80. So that is, a formula that you're going to need to know. Well, I don't know if I can highlight that no, because it's a picture, but there it is. That's a formula you're going to need to know. Um, we will give you some examples on how to calculate that, and that will actually come up in the critical care course, not right now. Inotropes are medications that alter the strength of contraction of the heart muscle. We sometimes want the heart to beat harder, and sometimes we want it to beat easier. The professor is on a beta blocker called atenolol, like a lot of Americans, and that makes my heart beat a little bit slower and a little bit less forcefully, so that hopefully my heart lasts longer, and I surely want it to. So, inotropes, positive inotropes make the heart beat stronger, and negative inotropes make it beat more easily, more gently, you might say. Calcium is important to the heart muscle, and we can give calcium to make the heart contract more strongly. Negative inotropes weaken the force of contraction. That would be like a beta blocker, like atenolol. The other kind of medication we talk about are vasopressors, and this is to raise blood pressure directly. Sometimes we just have to raise the patient's blood pressure because they're not going to survive without it. Some of those, this one you've definitely heard of, epinephrine, norepinephrine, phenylephrine, but epinephrine is the one you're probably going to use most, so I'll highlight that for you. And what they do is they impact systemic vascular resistance to either raise or drop the blood pressure. But in these cases, we want to raise the blood pressure. Patient might be in shock, for example. And here we have systemic vascular resistance versus pulmonary vascular resistance. Man, that is a lot more information than you need at this point in your training. But I will just enlarge it here so you can at least see it. Dopamine is a very common medication that you might as well learn that name right now. Dopamine, we use that to raise the patient's blood pressure when they're in trouble. Vasodilator medications would include nitroglycerin. Morphine actually is a very good vasodilator, and the calcium channel blockers. So don't worry about memorizing all that now. That's it. But you will certainly know that chart well by the time you do your critical care course. Here's the nitric oxide I keep talking about. It's amazing, actually. What we do is we administer that, and the pulmonary blood vessels open up. And you just see a tremendous improvement in the patient, especially in the case of neonates, in the neonatal intensive care unit. Some of you may want to go work in the neonatal intensive care unit. Nitric oxide is a pulmonary vasodilator. That's all you really need to know about it right now. Okay. Nitric oxide synthesis expressed in both the central nervous system and the peripheral nervous system. We make our own, but sometimes we need to administer an additional amount of nitric oxide. Yeah. All right. That's all you really need to know about that. Vascular endothelium cells do produce nitric oxide, but sometimes not a sufficient amount for the patient's condition, so we simply administer it. I will tell you, it's one of the most expensive things in all of medicine, about $20,000 per tank. So, wow. Nitric oxide causes widening of the blood vessels and a decrease in blood pressure. All right, but a better blood flow to the alveoli. That's what we're doing. Better blood flow to the alveoli so that the patient can pick up more oxygen. All right. Hypoxic vasoconstriction. If we have too much narrowing of the blood vessels to the alveoli, the patient cannot pick up enough oxygen. And we have to do something about that. What we usually do about that is nitric oxide. Okay, we're halfway through here, folks, and I am now needing to go check on a patient in clinic. So I will finish this a little bit later. We'll just call this the first half, and I'll do the second half and get it done today.